Thank you so much to the University of Michigan for inviting me to be a part of this curriculum. My name is Stephanie Tillman. I'm a midwife in Chicago. My primary role right now is as a PhD student in healthcare ethics at St. Louis University. I recently completed a fellowship in clinical medical ethics at the University of Chicago. I write online under the name Feminist Midwife, and I serve on some leadership roles for abortion training and access, queer community, and ethics. I'm speaking to you today from Chicago, which is on stolen land. These are the 5 primary tribes that were and continue to be here in the Chicagoland area. Since we are talking about trauma today, I wanted to give a broad content notice. There may be something that comes up that may have happened to you or someone you know. There may be something that I label as traumatic that you didn't know could be labeled as traumatic until today, or there might be something we're discussing that could make you uncomfortable and you're not sure why. These are options for how to engage in a safety plan. This presentation is being recorded, so you can always come back to it at a different time. But if you want to engage in a safety plan right now, some options would be breathing exercises, including counting a number of counts in, a number of counts you hold your breath, and then a number of counts you exhale. You can go to a safe place in your imagination, call someone you love, count backwards, like from 10 or 100, massage your hands. Midwives often refer to the pressure point between your thumb and your first finger. You can engage in prayer or meditation, and then you can also engage in sensory counting. So name 3 things you can see, 2 things you can touch, or 1 thing you can hear. And sensory counting, we'll talk about again a little bit later, is a really great way to help patients manage dissociation. And I've also used it with students who are dissociating or having a hard time. So by way of background, our field of pelvic health care is built off of trauma. So Black midwives and Indigenous healers cared for people in their community for a very long time before institutionalized white cis male medicine decided to deprofessionalize or discredit those healers, those communities, and start to learn their own medical knowledge. And in so doing, not only did they discredit those longstanding wise healers and midwives, but for them to gain their own knowledge, they examined forcibly on enslaved people without anesthesia for surgeries or procedures, even though anesthesia was available at the time. So what we largely know about birth in terms of institutionalized medicine, but also gynecology, largely comes from a traumatic background. The image on the bottom left is an exhibit by artist Michelle Browder to highlight Anarcha, Betsy, and Lucy, the 3 enslaved women who are attributed to a lot of the knowledge that we know today. The image on the bottom right is a poster from the America Plan, which allowed public health departments and police officers to forcibly quarantine and internally examine people who were believed to be promiscuous sex workers. And they were examined, including by police officers, to determine their risk or active disease well into the 1970s. Even our modern field of knowledge and practice exists on trauma. So the image in the top left is Dawn Wooten, the nurse whistleblower who came forward to talk about unconsented sterilizations and hysterectomies in ICE facilities. The image in the top right is an artistic rendition of the story of Kimberly Turbin, a self-identified sexual assault survivor who, when she presented at her hospital of choice in labor, and she believed she would have an empowering birth experience there, the physician informed her he would be cutting an episiotomy. She declined that episiotomy, and he proceeded to cut her 12 times. It was caught on video. It's one of the largest settlements in OB care. Bottom left is of Evelyn Yang, who came forward during her husband's presidential run to discuss progressive sexual assault issues and very distinct sexual assault that happened during her routine prenatal care. And in the bottom right is Allie Raisman, one of the gymnasts who came forward to talk about the sexual assaults of Larry Nassar, which for a very long time were believed to be normal gynecologic pelvic care. Trauma is very often referred to as the 3 E's: the experience of dehumanizing, shocking, or terrifying events, which can be singular or multiple over time, the effects of which often include betrayal of an individual person or an institution as a whole, and usually include a loss of safety. In gynecologic and obstetric care, very often we refer to sexual assault and intimate partner violence, but really trauma holistically can look like a lot of different things. So police violence, racism, being unhoused, living in poverty, not having access to health insurance, etc. So people can come in with a lot of different experiences of trauma, and all of these apply to trauma-informed care. Just like trauma doesn't exist in a silo, neither do people's identities. So very often these layer on top of each other. So some examples of people we often see in routine care who may have compounding traumas, whether from their identity or whether from their lived experiences, would include a trans person of color, someone who's undocumented in this country, who's living in poverty, someone who has a history of sexual assault, who lives in foster care, etc. Some of the outcomes of trauma, regardless of what type of trauma it is people may have an impacted sense of hope and optimism, unpredictable responses to major or commonplace events. They may personally internalize stigma and shame and have experienced people stigmatizing or shaming them. They may or may not have developed personalized coping mechanisms. Very likely they have decreased trust in systems, including healthcare, including education, including justice. And they may very well have a difficulty creating trusting or therapeutic relationships with anyone, whether that's a teacher or a family member, but also with healthcare providers. As it relates to obstetric care, we do know for someone with a known diagnosis of PTSD or past trauma, they're at much higher risk of having a premature baby, much higher risk of having low birth weight babies, much higher risk of experiencing birth as traumatic, all other things being equal, 12 times increased risk of postnatal depression, and then known issues with bonding with their baby, including decreased chest feeding and breastfeeding rates. So what previously was referred to as trigger warnings now are referred to as activators by the trauma community. And this can be anything that initiates a memory or a flashback to a prior event, typically the traumatic one. The individual person's physical reaction may mimic their initial reaction to the trauma. So that could be complete paralysis. It could be inability to speak. It could be ability to speak, but inability to move. It could be fight or flight. It really depends on the person. And the activation could be through any of the 5 senses. What often comes up in pelvic care that are known activators, particularly for sexual assault survivors, include the language, just relax and open your legs wide. These are very common phrases used by sexual assault assailants and often things that we say in healthcare, trying to come from a good place of getting someone into a position that we think might be more comfortable for them or into a position that we think might expedite the birth and so decrease the amount of pain that they're having. But really, survivors tell us again and again not to use these phrases. So finding other phrases would be really important. And I'll provide a resource at the end for that. For some people, just our physical location to the patient can be activating. So, for example, when we're in the outpatient setting, if someone is there for a pap smear or a bimanual exam, when we come into the room as the provider, really making sure that that person is not laying back until we're about ready to start the exam. So if we come into the room, have them lay back and still need to wash our hands or figure out the student or work out the tools that we need, that person's laying back, unable to see what you're doing, look at the ceiling, really would be difficult to engage with you from that position, and that can be really activating. Survivors also say that any act that we do to push someone's legs open, even if it's a very gentle back of the hand on the inside of the leg to say, this is my hand here, move your legs out to the side, even that can be activating for people. So really trying to use language to encourage people into a different position. And even if all these things, you're like, oh, I got this. This is exactly how I do my exams. Just the severe power imbalance between providers and patients in and of itself is activating. When we think about how people get through activating experiences or think about how they're going to manage themselves in an upcoming known trauma, These are called coping mechanisms. So this can be any strategy that someone comes up with intentionally or just innately starts to do that helps them function through that traumatic experience or prepare for one. Any of these coping mechanisms may appear to be dysfunctional or maladaptive. We tend to pathologize these things, but these can really facilitate someone's survival. Common in outpatient care, inpatient care alike are things like dissociation. So this would be, let's say you're engaging in a very ongoing consent process with someone during their exam, even perhaps talking about what you did over the weekend or something interesting other than the exam. If all of a sudden that patient stops talking to you and it seems like their mind just went somewhere else, consistently, sexual assault survivors want us to help them reassociate. So we should stop what we're doing, cover their body. If it's exposed, move around to the side of the table and start sensory counting. It's one of the first things to go to, but just talking to someone until they come back into their body and can continue into a consent process. Some people will engage in self-harm before, during, or after a visit, depending on what their activation is at the time. So that could look like cutting. It could look like substance use if otherwise they wouldn't be doing that. It can look like unhealthy or unsafe activities after the visit if they're needing to distract themselves from what happened. So really thinking through what an aftercare plan is for people if it was a particularly difficult visit or if they aren't sure if it will be. Some people may come across to the provider as angry, aggressive, hyper-aware, hyper-vigilant, really being cautious about who we're labeling those things. Typically, those are racistly applied to patients when really it could just be the person and their personality, and that's okay. It's our job as providers to be like, right, let's work through this one thing at a time. I'm here to make sure you understand everything and that we're on the same page. Or it could be related to trauma. So if someone, for example, if you're giving pap smear results, if someone says, what do you mean? How could you know that? It was just one test, and they're interrupting or their tone is coming across in a way that feels like a lot to you. Again, you got to practice being ready for those things and creating a really calm, safe environment for people. And then again, thinking about substance use. So people may drink heavily or come in after smoking to prepare themselves for the visit, or they might do those things afterward. So if they do those things before the visit, really thinking through for you as the provider, are you okay to consent them for the visit based on their level of intoxication? Or is that perhaps a lead into saying, okay, if you need to do this to get through the visit, today's visit's going to be talking about your boundaries, your consent process while you're at this level of substance use at this time. So why does trauma matter? One reason for some people is if they experience a pelvic trauma, sexual assault, or a rape, if they do seek healthcare afterward, whether with a provider they know or with a forensic exam in an emergency room, the experience of those two pelvic circumstances, either the assault or the exam afterward, can link the memories between the two. So that means even if we're in meeting someone for the first time, or this is a patient we've known for a long time, if we're just doing our routine care, any part of that care could be activating for someone based on a past trauma because the trauma and the healthcare are linked. Trauma also matters because people may only come when it's absolutely necessary, like someone showing up in labor with no prenatal care, or someone showing up when they've had the worst pelvic pain that's been growing over years. So really not stigmatizing, not judging patients when they come in at the last minute. There could be a lot of reasons why that happens. They may be very fearful of visits. They might be very aware of how quickly we're moving throughout our day and worry about how much more time they need from us. And again, they may be really critical of what we're doing or how we're presenting information or how we're talking about things. And they have a right to. They're the patients. It's our job to do better. Trauma also matters because some providers are terrible. Some people start exams without ever introducing themselves, will complete an entire exam without speaking to someone, or be very rough with their palpation or manipulation. Trauma also matters because what people experience outside of the healthcare setting, just in general social life, also maps on to what exists in the healthcare setting. So Birth Monopoly is a wonderful resource for things related to obstetric violence, and they've created what's commonly referred to as the rape culture pyramid in social life and translated it into what's common rape culture within obstetric violence circumstances. So what's often normalized, for example, joking about birth plans, maybe specifically about minimizing cervical exams, when you normalize something like that, then it's easier to move into degrading the patient who's asked for those things, openly making fun of their birth plan, or openly disregarding certain things. And once you've moved from normalization into degradation, it's much easier to think of the environment as one in which someone could be assaulted. So for example, if someone gets an epidural and they're asleep, providers doing a cervical exam while the person's asleep without ever consenting them for that, or even breaking their bag of water while they're asleep and never talking about it. So what are we trying to do differently? Trauma-informed care changes the conversation from what's wrong with someone to what happened to them. And what's really important about this shift is that it's not, oh, what happened to you, in a really patronizing or pejorative way. It's more like something happened to you, something important has happened in your life, and we should be attentive to that. And really, we never should have to know what that thing was. No one should have to disclose to us. No one should have to tell us for us to try and create a lesser traumatic healthcare environment or an atraumatic healthcare environment. We should just do it for everyone. The ideal of trauma-informed care is to acknowledge the prevalence of current, recent, and past trauma, emphasize the range of effects on a survivor's physical and mental health, and guide how we interact at the interpersonal level and at the institutional level. The framework is meant to really harken back to what brought us to healthcare and to patient care in the first place. Sharing control with people, really being patient, building rapport, respecting their boundaries. If they don't want to do something, today's not the day, let's figure it out. Really thinking through nonlinear healing, like today a certain thing's okay, or at this point in labor, a certain exam's okay, but in 5 minutes it might not be okay anymore. And that's all right. That's part of trauma and healing. Our goals are for better patient outcomes. People are more engaged, they're more likely to follow up, they're more likely to understand what we're talking about and be involved in their care. And then we're more likely to understand, perhaps they might disclose their traumas, or perhaps we might know more particulars about what's going on with them. And then we can be supportive in figuring out coping mechanisms while they're in our care or in their life more broadly. What sexual assault survivors ask for in particular is consent before and during all exams or procedures, anticipatory guidance on sensations. That would include really being honest if something feels like pressure or if it's going to feel like pain. Because if you say pressure and then you put on a tenaculum and it's the worst pain somebody's ever had in their whole life, that created an experience of an incredible loss of trust. Someone then thinks they're not going to really tell me what something feels like. I'm not going to trust this person. So really, you'd rather give a worst case example of what something's going to feel like. And then if someone really doesn't have anything near that level of pain, then you've built trust with them, because they're like, oh, okay, they really gave me the worst of it and I was okay. Helping to manage dissociation, which we talked about. And then this last point is how it's framed in research, giving patients as much control and choice as possible in healthcare. I would argue that something that's really wrong with healthcare is it's framed around us having all the power, patients coming in and we giving power back to them piecemeal. And it should be flipped. Really, the patient should have all the power and then they decide which pieces they want us to share with them. So really thinking through how to disrupt that dynamic. What does this look like for pelvic care? So just broadly speaking, a pelvic exam is when someone lays down and exposes their genitalia to someone who's a stranger in a position of power. The patient may feel like this exam is a medical necessity rather than an option. Something may be inserted into their body, possibly painfully, that may result in anxiety in and of itself or might result in pain. And each of these points that has an asterisk meets criteria for traumatization. So again, all things being equal, the exam itself is traumatic for people. Something I'm arguing in my doctoral work is there are certain experiences that I refer to as exceptionalized care that cause many providers to just do something a little bit differently than what they would normally do. So if we know that this is a patient's very first pelvic exam, or that they're queer, or that they have a history of sexual assault, or that they have a history of painful exams, for many providers, there's this shift of, okay, I'm going to do a really good exam for you. Like from start to finish, I'm going to be as gentle and patient as need be because of these certain experiences. And something that I'm hoping to argue, well, ideally, would be that exceptionalized care should just be normalized care. I'm also separately seeking to argue for us to really start to be clear about what's involved in a pelvic exam. And I'm doing so very bluntly by calling a pelvic exam penetration, because what that is it describes specifically to people we're taking care of that we are moving from the outside of their body to the inside. Not everybody understands what a speculum exam is or what a bimanual exam is. And that might mean different things to different people. So cis heteronormativity really assumes that most people engage in penetrative sex, that they do so regularly, that it's not necessarily a discrete particular experience in their lives. And this assumption of normalization of penetration, particularly vaginally, is not appropriate for anyone we're taking care of, but particularly for queer people. Again, if someone has described that they're sexually active, unless you know more, and you should be asking more if it's appropriate for the conversation, we should not be assuming that that means that someone's engaging in penetrative sex. We shouldn't assume that that sex is painless or that any type of penetration is painless, including if they're using internal menstrual products. And we really should be clear about each part of the exam. That would include when we're teaching students how to do exams while someone's under anesthesia. If that patient has not been informed that a person or multiple people will be doing exams under anesthesia, I'm arguing that that is medical sexual assault. Reasonable accommodations in all settings, particular to trauma-informed care, would be to position the exam table so that the patient is able to see you, because then they can see everything you're doing. There's no question about where you are. If you showed them the table with everything on it and you haven't gotten up to get anything else, they can trust that what they saw is what's still there. Offering a chaperone, these guidelines have recently changed, but being really clear about who that chaperone is, how they're trained, what their role is, and how that's different from a support person who would be helping them during the process. Some patients want to know all the instruments or parts of the exam beforehand, or they want you to talk them through each step throughout. That depends on the person. Some people may want to know nothing. And then you really need to be clear about, okay, what will consent look like in a way that we're both comfortable for how we proceed through this exam. It's really helpful to show a picture or to use plastic models to show people, I'm moving from this part of your body all the way to the inside here. And some people don't know how far inside of their body we're going. And that can be really illustrative in making sure people are on our same page. Offering a mirror. If you've already positioned the exam table so that they're able to see you, you're still in a position then for them to be able to hold a mirror so that they can talk you through what's bothering them, or you can even show them different parts of their anatomy. One thing that people worry about with this positioning or with someone holding a mirror is somehow that's a position that then makes it really difficult to get to the cervix. And I would just really argue that's not true. We should be telling people to try and flatten their back against the exam table, or you can even say, try and tilt your pelvis upward. We don't need to overgeneralize that people have to be laying all the way flat on their back for us to be able to do an exam. Make sure there's enough lubricant on the speculum. Historically, a lot of providers thought just running the speculum underwater or using whatever someone's natural lubrication was would be enough. That is not the case. It is very uncomfortable for people if there is not adequate lubricant on the speculum. It is also really uncomfortable if you start an exam with a speculum totally inappropriate to that person's anatomy. You cannot assume what size speculum someone needs based on their disclosed sexual history, which we just talked about, or based on their body composition, always start with the smallest speculum. There's really rare need to ever begin with a large speculum. You can always offer speculum self-insertion. That can be really empowering for people, particularly if they describe pain externally during the exam. And you can always offer self-swab. So if someone's just there for HPV screening, or if they're just there for a wet mount, someone can self-swab. You don't always need to look, or you don't always need to use a speculum. And then if you get through the whole exam, nobody rescinded consent, nobody said that anything hurt or was painful, it's really important that we don't assume like, oh, you did a great job, that went easier than we thought. In actuality, that can be really dismissive of what someone's experience was in that moment. So instead, after the exam's finished, say, how was that? Is there anything that I could have done differently? What should I write down that worked well so that I can tell other providers? Some of the exceptionalized accommodations that we make that really should be normalized for everyone is to make sure we're really clear about what our personal professional process is for informed consent before and throughout, and make sure that the patient's on our same page. We can always offer progressive visits. So the very first visit, just build rapport, start counseling, discuss boundaries, discuss their own anatomical language, make sure you're on the same page about everything. And then the next visit could be, now let's talk about the exam specifically. And then following visits can include the exam. You can always find reasons to bill. So that counter argument is not welcome here. We can find ways to progress visits as needed. Here's a big plea for the plastic speculum, because then we can provide them to patients. Get little packets of gel, the plastic speculum. People can take those home with them and get used to the sensation, the sound, how to self-insert, etc. We can always offer an external lidocaine gel the day of the visit that the person can self-apply, or we can apply externally, that can help with some of the discomfort on the labia or at the introitus. We can always offer anti-anxiety medication for people to take the night before or day of, and then discuss possible coping mechanisms. There's so many ways that we can be supportive of people's trauma or activation in the clinic setting. And finally, and maybe this is actually a really good place to start, is if it's someone who has a particular trauma related to the identity of the provider or related to not feeling safe outside of their own community, whether that's race, whether that's sex, gender identity, etc., help them find a concordant provider. There can be a lot of safety in being taken care of by someone who identifies similarly to you. Many things might come up during an exam that could let you know that someone's experiencing trauma or activation. Some obvious verbal ones would be if they start crying, or if they say ouch or stop. And ouch and stop, I feel like in healthcare, we've just gotten so used to hearing these things like, oh, we're almost done, like, oh, we'll just finish, don't worry, just another second. If someone says ouch, that means that you have caused them pain, and we need to hear that, and we need to pause and say, okay, let's take a minute. Let me figure out what I can shift in what I'm doing. Or if they say stop, that's them rescinding consent. You need to stop what you're doing. They no longer consent to what you're doing. We don't need to hear these as soft words anymore. These are firm. Some nonverbal cues that come up really often would be someone closing their eyes, covering their eyes, trembling in one or more parts of their body, grabbing onto the table or grabbing onto their legs, clenching their pelvic muscles closed, changing their breathing pattern, closing their legs, or moving away from us. If any of those things happen, we have to stop the exam and we need to check in with people. Doesn't matter if you just need another second, or doesn't matter if it was really hard to even get to that point of the exam and you worry that they'd go through a lot to be able to get to that point again. We need to stop. Patients also are very explicit. They want anticipatory guidance of what possible activators could come up next time. So particularly if your institution refers for anatomy scan and it always includes a cervical length, telling people that's probably a transvaginal ultrasound. Let me just tell you what that's about. Showing people what that looks like, and then telling them they can insert the transducer themselves, and letting them know that is covered in a condom with a whole lot of lube on it. Just letting people know kind of the obvious activators that might come up. Same if you're referring for pelvic pain or pelvic mass, if that'll be a transvaginal ultrasound, being clear. letting people know if upcoming visits might include a chest or breast exam, internal or external examinations, if a speculum exam might be indicated, and letting them know if it's not me, if it's a different provider, you can self-swab, or for these certain things, like for a herpes culture, the provider would need to swab. So if you're looking for some more information, for example, about shared decision-making and sharing power, I wrote this paper with two other providers that includes this graphic of just walking you through what that exam looks like, what that conversation can look like. This paper specifically around how we do not do a bimanual exam annually, nor automatically with a pap smear anymore. That's confusing to patients, let alone providers. So what does that look like, and how we engage in a shared way? If you're looking for scripting about how to change certain terms that I brought up today, like just relax, there's so many things to say other than just relax or open your legs wide, lots of different options. What's most important is that you find language that works for you, because you want to make sure that you feel comfortable interacting with the person in front of you. I have a free script about how to talk someone through what might be a very difficult exam during their labor in ideally an atraumatic way. Certain things have worked for me in the past and work for students and residents in my care. So I offer this up. And just a note, this is a very abbreviated talk of a longer training I do for students and providers. So thanks for letting me run through it so quickly. And thank you again to the University of Michigan for having me.